Next, from Richmond, Virginia, a comparison of revised frailty score range association with national lower extremity bypass outcomes by gender by Dr. Dittman and colleagues.
All right, I appreciate that kind introduction. My name is James Dittman, actually not a doctor quite yet, fourth-year medical student, but thank you for the opportunity to present today. We have no disclosures. It is well known that vascular patients undergoing surgery tend to be more frail than surgical patients as a whole. Frailty has been shown to be predictive of adverse postoperative outcomes, including mortality, in a number of retrospective studies, prospectively differentiating frail patients from non-frail patients in a more accurate way than the eyeball test, however, remains a challenge. No one system has been accepted as the gold standard for defining frailty. In fact, over 67 instruments have been described to date across the medical literature. Fundamentally, frailty is either defined as a sum of age and symptoms that indicate biological decline, such as weight loss, weakness, and walking speed, or health deficits, including comorbidities and disabilities. A novel approach for defining frailty has been to use variables routinely collected for large surgical quality improvement databases. Using this approach, frailty score ranges for specific postoperative risks can be defined so that surgeons can identify and counsel frail patients when considering operative management. The frailty system that I've been describing is the Risk Analysis Index, or RAI, which was developed by surgeons in 2017, calibrated against 30-day mortality. Initially validated in the Veterans Affairs Surgical Quality Improvement Project, or VASQUIP database, which is 92% male, the RAI was recalibrated and externally validated in the American College of Surgeons National Surgery Quality Improvement Project, NSQIP database, 58% female, in 2020. Scoring for the RAI-REV is shown here on the right. As you can see, age, cancer history, and functional status play the largest roles in the scoring system. Total RAI-REV score ranges from 0 to 81, with scores of less than 25 universally considered to indicate non-frail patients. We sought to extend application of the RAI-REV to specific vascular populations and determine whether this frailty score remains equally predictive of mortality in both male and female patients undergoing lower extremity bypass. We also wanted to investigate the relationship between RAI-REV score ranges and other post-surgical outcomes reported by NSQIP. We limited BiPAP cases in NSQIP to elective cases performed from 2015 to 2019. Supplemental outcomes from the targeted lower extremity open LEO database were paired with the core database using case ID numbers. We defined extended length of stay as an additional outcome for these cohorts, top quartile stays being those longer than 7 days. Cohorts were divided by EMR recorded gender as recorded by NSQIP. For univariate analysis, all continuous variables were compared using unpaired t-test and binary variables with Fisher's exact. A multivariate binary logistic regression was performed to generate adjusted odds ratios for all the postoperative outcomes defined by NSQIP in 5-point increments for frailty score ranges from 25 to 45. 8,155 elective cases contained all components needed to calculate a frailty score. Despite a majority of cases in the NSQIP database overall representing women, in this vascular subset, there was a predominance of male patients of 69%. While non-binary gender has been added to NSQIP in recent years, no LEO patients were recorded with a gender other than male or female. In both cohorts, the average patient had an RAI-REV score that was non-frail or less than 25. Men undergoing surgery had slightly higher frailty scores than women overall due to slight but significant differences in age and functional status at presentation as shown here. Notably, there were not significant differences between the prevalences of any comorbidity frailty score components between groups. In most remaining perioperative factors, similar prevalences were demonstrated between cohorts even when differences were statistically significant. While there seemed to be increased graft utilization in women in comparison to men, this may be reflective of incidence of prior ipsilateral intervention. Women did tend to present with more advanced disease. 66% of women versus 57% of men exhibited critical limb-threatening ischemia with either documented rest pain or tissue loss at presentation. When it came to outcomes, all significant differences in the univariate analysis were higher in women than men. Postoperative bleeding, specifically bleeding requiring transfusion or secondary procedure, disposition to a skilled nursing facility, postoperative recovery longer than a week, and readmission rates were the most notable among these. Outcomes that occurred infrequently tended not to be significantly different between cohorts, most notably mortality, combined MI or stroke, as well as cardiac arrest. Before diving into the multivariate analysis, I just want to revisit that the majority of elective bypass patients had non-frail RAI-REV scores under 25, and to highlight that especially beyond frailty scores of 40, our sample size became greatly limited. This distribution is similar to what has been published for general surgical cases as well. Interestingly, the proportion of non-frail patients undergoing bypass, 69%, is far less than that reported when the entire surgical population in NSQIP was used to externally validate RAI-REV frailty scores at over 80% non-frail. This finding does support our perception that vascular patients are more frail than the general surgical population overall, even for vascular cases that are considered elective. Mortality was the first outcome that we examined by frailty score range. As you can see from the univariate analysis, as RAI-REV score ranges increased, there was a dose-dependent increase in 30-day mortality in all cases, as well as in women and men, respectively. Once adjusted for covariates, there was no significantly increased odds for mortality in women or men with RAI-REV scores between 26 to 30. In men with frailty scores between 31 to 45, significant odds ratios ranged from 7 to 45. Beyond a RAI-REV score of 45, and at most score ranges in women, the significant odd ratios were limited by sample size. Extended hospital course and disposition to a SNF were also related to RAI-REV score ranges in a dose-dependent manner in both men and women, with significant findings at higher score ranges likely limited in women by sample size. Even mildly frail patients with RAI-REV scores between 26 and 30 had significantly increased odds for these outcomes, including being twice as likely to have disposition to a skilled nursing facility as compared to patients who are non-frail. Bleeding, myocardial infarction, and cardiac arrest showed dose-dependent increases that were significant in some score ranges, but less dramatic overall. In women, there were too few events to generate significant adjusted odds ratios for most score ranges. Importantly, the few odds ratios that were significant in women were similar to those in men. Now, there were several limitations of our study. Our sample was limited to institutions that participate in NSQIP, and we do not know whether there was any sort of regional predominance among the data. Our study was limited to 30-day outcomes, and most notably, despite finding a comparable effect in women and men at lower frailty score ranges for several outcomes, at higher frailty score ranges, sample size constraints limited significance, especially for women who are represented by less cases overall. In conclusion, surgeons screening open bypass patients for frailty should consider an RAI-REV score cutoff of greater than 30 to indicate patients at increased risk for mortality, which ranges from 3% to 15% with advancing frailty scores, as compared to 1% or less in non-frail patients. Our findings suggest that the RAI-REV could also be used to screen for likelihood of additional rehabilitation needs in this patient population. Where the study had appropriate sensitivities, we did not find any significant differences between male and female cohorts, which suggests that the external validation of the RAI-REV in a general surgical cohort extends to all the vascular case subsets. In the future, we do hope to engage in collaborations to extend this work to long-term outcomes of lower extremity revascularization, as well as to other open vascular and endovascular procedures. I'd like to extend my thanks to the Vascular and Endovascular Surgical Society and the VCU Health System for making this presentation possible, and be happy to answer any questions at this time. Thank you.
Thank you very much. The paper's open for discussion. Dr. Corrier?
Hi, Matt Corrier, Ann Arbor, Michigan. Enjoyed this. Your group does good work with this stuff. My question here is, this is a very common thing. We have a retrospective look where all the decision-making happened upstream of whether. So how many vascular surgeons see an RAI calculation before they make a decision to proceed with surgery? Is my first question, because I think you have an implementation problem here. My second question is, did you look at any of the alternatives to lower extremity vascularization? And are these outcomes any worse with amputation, or did you consider like palliative impacts on patient well-being? Because without a comparison group here, I think at least for some of our patients with chronic limb-threatening ischemia, you might be leaving folks without a good alternative when they identify these frail patients. Great presentation, really thorough, good analysis. Thank you.
Absolutely. Both of those excellent questions. I think to start answering with your second question with regards to kind of the limitations of NSQIP in terms of being able to kind of have another cohort that you can be examining with, I don't know that there is really a solution that's already in the pre-existing data. However, in terms of how many surgeons are using it currently, this obviously is a pretty new frailty score, 2017, recalibrated in 2020. There has been a publication where, a large endovascular and surgical group has actually applied the RI-REV scores prospectively in a clinic setting and found that they thought it would be feasible, but I think there's a lot of work to be done there.
Final question. Do you think we need to separate these out per procedure? I mean, the RIA was sort of developed to deal with the entire sort of vascular population. Is it necessary from a validation standpoint to look at every single thing we do, or are we going to find the strength of it because it basically applies to the sick vascular patient?
Absolutely. I don't know that the findings will necessarily be that different when we're considering elective cases, but I do think that it would be worthwhile to extend this at least to, considering some of the more emergent vascular cases, because I think that when it comes to some of these outcomes, whether it's mortality or rehabilitation, that we actually may find that the frailty score has an even more striking impact in being able to predict those. And kind of as a follow-up of that, and pertaining to the last question in terms of really more how should this be used, especially in patients that may have no other better options, obviously it's part of the discussion with the patients. I don't think that we'll ever be at a point where we just have a score cut off and we say, no, you're too frail for surgery. But I think if you're having the discussion with the patient and they have a high frailty score, that you can with confidence say, in a national sample, patients with your frailty score have twice the likelihood of needing rehabilitation, of being here longer than a week, and potentially dying from this procedure. And I think that's just helpful as part of that conversation with those patients, so they know.
Or perhaps those are patients that you might offer a more aggressive endovascular strategy for if you know up front that the mortality is higher, so something to consider.
Absolutely.
Thanks, James. Congratulations.